Shoulder arthroscopic procedures in the outpatient setting will be discussed by our next keynote speaker, Dr. Bancha.
Good afternoon and Mabuhay. I'm Dr. Bancha from Thammasat, University, Thailand. Thank you, my fellow Dr. Pratchaya, Dr.CJMendoza, and Kat from Philippines for preparing the document. Thank you, the organizing committee, Philippines Orthopedic Center, for inviting me. Today, my talk is about the common shoulder arthroscopic procedures highlighted in case in outpatient setting. Since the early 2000s, there has been increasing interest in ambulatory surgery. The National Health Service have adopted day surgery as the norm of the elective surgery since 2004. Despite being driven by the external factors such as medical insurance policies and the rising need of bed capacity during pandemic, the big reason for the evaluation of our practice is to improve hospital system such as surgical and anesthetic technique, which allow patients to be comfortably discharged after the surgery. This practice has numerous advantages that provide increased patient convenience and lead to cost-effective and efficient delivery of healthcare. This study done in 2016 and conclude that three things are important in establishing day surgery, and among the three, the most important is organizing ambulatory surgery to ensure quality and safety of the care. Organizing ambulatory surgery to ensure quality and safety of care means we need the infrastructure to do it well trained staff and the guidelines on how to go about doing it. However, it's not yet widely used due to challenges like general anesthesia and required post-op monitoring, procedure that increase operative time, and other factors like uncontrolled pain after surgery, bleeding after surgery. To deal with this problem, we need patient-centered, multidisciplinary approach, which is unique to our specialty and facility that will optimize their perioperative experience and facilitate faster recovery. A holistic perioperative system consisting of proper patient and family education, nutritional build-up, multimodal anesthesia, and adequate follow-up care is needed to ensure good outcome and patient safety. Pre-op planning and well-coordinated surgical team ultimately reduces surgical time. In time, we have been able to perform more procedures arthroscopically, which benefits intra-op and post-op cost of the patients. We have a very big team composed of nurses, medical students, residents, and fellows. You can see how big our team is. Don't fight with your boss, anesthesiologist, because they are always on the head. You will never win, and your surgery will be struggle. During this 3 years pandemic, our NS team improved their regional nerve block technique a lot because they're scared to intubate the patient. That's good for the patient and also good for the surgeon. Their surgery is not for all the patients, so we need to know who is suitable to be the outpatient procedures. Actually, there's only two factors, patient factor and doctor factor. We'll discuss in detail. Number one, the patient factor. The patient should be reliable and compliant. They should have good family environment, reliable caretaker, and should have telephone or social media that we can contact them. The patient should be healthy enough, less comorbidities, because Patient safety is our first priority of ambulatory surgery. Doctor factor. First is your NS team. They are the key persons who change our service. Painless and safe surgery is the key of ambulatory surgery, right? We are very lucky. Our NS team is so kind, so cute, and very good hand skill. Another doctor factor is surgical technique. The type of surgery and surgeon skills are most important. We are lucky because we are the keyhole doctor. Most of the shoulder surgery is keyhole surgery, less breathing, less morbidity, but very painful, very, very painful. So the goal of AmbulatoryShoulderSurgery shoulder surgery is to control the pain after the surgery. I'm honored to share with you our experience in performing common shoulder procedures. The first patient is 52 years old lady, just right shoulder pain for 6 months and limitation of shoulder activities, especially overhead activities. So the near test positive, Hawkins size positive, and job test positive. The X-ray and MRI show pathologic acromion hook spur and bursal side tear of the supraspinatus. For this patient, we have performed the awake arthroscopic subclavian decompression and rotator cuff repair. The bed chair frame should be convenient, so the patient feels like he's sleeping on the recliner chair. This is our in-house innovation, Thammasat University MTech frame. As you can see, the patient is not intubated, and you can hear me talking to her immediately after the surgery. She's quite happy. This is 6 months after the surgery. She's a nurse. She's happy with the result. The next patient is 63 years old female. She has chronic right shoulder pain for 4 years with severe limitation of the shoulder motion. She is diagnosed with adhesive capsulitis and failed conservative treatment. We perform the arthroscopic capsular release, subclavian decompression, and manipulation under the scaling nerve route. The advantage of doing this is that we can talk with the patient all the time. You can hear me talking with the patient, and she's quite happy. She can go home on the same day.
เขาได้ยินเสียงป้าไหมได้ยินป้าสบายดีไหมคะโอเคป้าเจ็บไหมครับเจ็บไหมคะ
We perform the arthroscopic capsular release with the basket punch and RF, followed by acromioplasty and shoulder manipulation. This video shows 1 month post-op. The patient have much better range of motion and less pain. Next patient is 22 years old male with recurrent shoulder dislocation. So he has anti-apprehension test positive, relocation test positive, and the O'Brien test positive. The X-ray apical oblique and striker notch will show heel sac lesion without obvious glenoid bone loss. The MRI show Bancha lesion with patulous capsule label recess and off-tack heel sac lesion. We did the shoulder examination under anesthesia and used the TU supine position. I did awake arthroscopic pancapsular repair with limb massage in this patient. The benefit of using this position is that the surgeon happy. I don't need to twist my back and abduct my shoulder like this during the surgery. I used to have the AC joint problem, so I stopped and developed this technique. The anesthesiologist happy because it's easier to control the airway during the surgery. And also the patient happy because it's more comfortable and bearable comparing to the decubitus position. I plan to do arthroscopic pancapsular repair with limb massage. I start with the limb massage first because we have more room to work. It's easier at this time. But I did not tie the knot at this time. Followed by the label detachment, label mobilization, and label repair. You can see that even this extensive surgery is also possible because the improvement of anesthetic technique and the patient positioning. So this is the post-op 2 months after the surgery. The patient have better range of motion and very happy with the result. This last case is not the arthroscopic surgery, but it is a very extensive surgery. She's 88 years old female. She has proximal humerus fracture, severe proximal humerus fracture. She has OCVA, she has left catalytic stenosis, and the internal medicine said you cannot operate in this patient because it's too risky. I discussed with the patient and her relative that I plan to do the awake surgery for her. The X-ray and CT scan show severe comminuted head split fracture. I plan to do the reverse shoulder arthroplasty for her, but the cardiologist said it's too risky. The risk of recurrent stroke is more than 60% because she had OCVA and left catalytic stenosis. But I discussed with the patient and her relative that we plan to do awake shoulder surgery. We will monitor the patient all the time. They agree with me. We put the catheter into the brachial plexus to control the pain intra-op and post-op. So no worry about the pain after the surgery. We can control it. As you can see, the patient was under neuromonitoring because we were concerned about the stroke. This case was done under interscalene nerve block and sedation, no intubation. We talked to the boss, our anesthesiologist, all the time. The surgery was very smooth, and finally, we can finish our job, the reverse shoulder arthroplasty with tuberosity fixation. This is her 3 months after the surgery, without hair, but the patient is very happy. She has good strength and good shoulder motion. The post-op monitoring or online call is very important, especially the first 24 hours. We can use the video call from any social media like Viber, right? It's popular in your country. WhatsApp, Zoom, Line, anything. The patient will be very happy if the surgeon call her. Take-home message. Day surgery is becoming the trend. Proper patient selection is crucial. Improved anesthetic technique is the key. Manage problems that can lead to admission, such as control the post-op site breathing by meticulous surgical technique. Control post-op pain by multimodal pain control. I would like to invite our Filipinas friends to Thailand. We have APCAS tourism meeting 29 September in Pattaya. It's time to reunion. Thank you and see you soon in Pattaya. Bye bye.